All right. Again, thank you all for joining and welcome to today's session for Pediatric Readiness Recognition Programs Collaborative. This is our 10th session. And before we get started, we would like to acknowledge that the Pediatric Pandemic Network and the EMS for Children Innovation and Improvement Center are supported by the Health Resources and Services Administration. The contents of those of the author and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. And as a reminder, today's session is being recorded and will be posted on the EIC's website along with the presentation. And as always, we look forward to having an interactive session with you all, so please feel free to raise your hand and come off mute throughout today's presentation. And during the session, we will get started with a few brief housekeeping items, and then we're going to turn it over to the teams from Kansas, Connecticut, North Dakota, Wyoming, and Northern Mariana Islands. To finish up today's session, we will share a couple updates and review our next steps. And as much of the work is involved in developing and implementing a recognition program is happening within your individual advisory committees, a benefit of participating in the collaborative is your opportunity for our participants to gather virtually and to share your successes and challenges, both big and small, bringing together individuals from a variety of backgrounds and varied experiences within your unique landscapes, allowing participants to learn about different settings and adopt the best practices shared by others. So as we kick off our next phase of the collaborative and begin having members of participating states and their territories share updates on their pediatric readiness recognition programs, we would like to extend a special thank you to our first presenters for sharing. Your willingness to share your experiences is greatly appreciated, and we look forward to a robust discussion where we can all learn from one another's experience and insights. So please use this time to learn about your peers' recognition programs by asking questions about their experiences, and those who are sharing an update may also use this time to ask questions of other participants. So we will go ahead and transition to our updates if there aren't any questions. I'm going to go ahead and hand it over to our team from Kansas. Go ahead and come off mute and I can move the slides for you.
Hi, everyone. I don't know why we're making the rookie go first, but here we are. Go ahead to the next slide, please. So back in 2020, my predecessor had started the PRRP program, which was just for hospital. It was ED only. But because of the pandemic and then some staffing changes, it never really got off the ground. So when I came in, I revamped it, renamed it the CAPE program, and that is going to be for both pre-hospital and ED. We added a new tier and of course updated some of the minimum criteria. And we don't have anybody recognized yet, but we do have one facility that's in the pilot process. Next slide. So we've got a steering committee going, one for pre-hospital, one for in-hospital. And we're going to talk about how often we should re-verify, what certification level, especially when it comes to pre-hospital, should be involved in like site surveys. And then we will all answer to my advisory board. The application process, I was able to just basically copy paste from the PERC and update the form. They go ahead and they send in the application with their policies and procedures so that we can look at all of that before we actually schedule the site survey so that it's not a complete waste of time. And of course, the verification process is still to be determined as we get moving towards the steering committees. Next slide. So the implementation checklist is pretty much, like I said, it was brought over from the PERK program for the ED. The pre-hospital, we had to completely redo. And thankfully, we are able to use the PPRP. A lot of that data is going to be the same, so we can implement a lot of that into the recognition program. Next slide. So right now I'm waiting on my director to approve all of the paperwork before we send it off to HRSA. And then we can move forward with that one facility who's actually done a great job, and they have turned in all of their stuff and they're just in a holding right now, which is unfortunate for them because they've worked so hard. Was that our last slide?
Thank you so much for going first. Appreciate it. What questions do you have for the group here? Maybe about the development of your program, or we can also open the floor up to anyone who has questions for Jessica.
I don't have any questions.
And if you do have a question for Jessica, feel free to raise your hand or come off mute. Looks like
this is Cindy from Maryland. What platform or format do you have your application in?
I did it in Word. Nope, that's not true. We did it in one of the I can't remember the name of it, but it was like it was one of the Microsoft, not Word. Help me out here, guys.
using Microsoft Forms, like a fillable thing.
No,
Publisher.
it wasn't PowerPoint. I'm looking for it, guys. I'm sorry.
Not publisher.
Spreadsheet like Excel?
It was kind of like Excel.
That's helpful to know that it was done with Microsoft, and it is a document that is then a digital or a paper document. We're looking at Smartsheet, and it's difficult for at least some of us, me, to program.
I think it was Project Manager. And there's also another program that we're using to upload documents from the facility to us, which is still being developed. And for the pilot, we just they were the first ones to reach out. Like, they had heard about the PERK program years ago, and we're kind of doing their stuff internally to get ready for it. And then she sends me an email and she's like, here's our application for the PERK. And I was like, oh, well, it's changed a little bit. Here's the new criteria. So they weren't completely thrilled by that, but they worked through it very quickly.
Any other questions for Jessica?
Thanks, guys.
Thank you. All right. And I think for Connecticut, we're handing it off to Dr. Goldman.
Yeah, can I share or?
You should be able to, yes.
Okay, one second. Apply. Okay. Oh, can everyone see my slides?
Yes.
So Megan's in transit, and I know she's on the call, so she can chime in, but I'll just go through the slides for us and give the Connecticut update. I guess I'll start by saying, we're focusing first on hospital-based recognition programs, and then we'll learn from that experience to expand it to EMS as a next tiered kind of initiative. I do want to share, and I don't know if we've alluded to this in the past, but putting it all in context, Megan and I were interviewed by the Wall Street Journal about, and I know that likes it, about the Always Ready for Children hospital designation program that was being started up in New England. This was a baby project of Dr. Mark Auerbach and Vicki Barnes, and was really going quite well. And then the pandemic hit. And then somewhat during the pandemic, the leadership changed. And so we inherited sort of like some framework of this recognition program, which we were excited to learn more about and get involved with. But then we had to kind of answer to the public, so to speak, and speak to this reporter at the Wall Street Journal. And it was challenging. It was challenging because we didn't create that program ourselves. We didn't really know much about its validity or its verification process. And some of the concerns that were brought up by the reporter and then subsequently put in the article were concerns that frankly we shared, and felt as if, the two of us at least really felt that if you're going to put this term pediatric ready on a hospital billboard or website or a highway exit for that matter, like that really has to mean something. And we were of the opinion that it should mean something really strong. So in the past, New England programs developed a 3-tiered system. And there were only a few hospitals in Connecticut involved. Those that were our shining stars for sure. So it meant a lot to them. But again, we didn't really have the opportunity to form it ourselves, and we were looking forward to revamping it. And actually, when this collaborative came around, we were like, this is just in time, because before we go on our own and revamp our statewide program, we would love to have the insight of the country, so to speak. And so we were really excited to join this collaborative. We really took into account like the good EMSC work, state partnership work, whereas like to do this work, we really leaned on our family advisory network, our community ED PECs, our children's hospital PECs, both at Yale and Connecticut Children's, and then of course our executive state partnership team. Our application process is not formalized just yet, but we will ensure that it is a really reliable, communicative PEC. With a C-suite buy-in will be essential during our application process, and that we will be including some element of the pediatric readiness scores, because when we think of validity, higher scores predicting better outcomes for children, ultimately that's part of what we really, really want. Additionally, our verification process is not finalized just yet, but we will do the work to ensure that what people say they are doing, they are actually doing. And whether we visit hospitals in a virtual manner or drive up, and around the state to pay a visit, will certainly be a part of it, because I think that's also, we think that's very important. As I alluded to, like we plan to have our recognition in our state be a high bar, and to include family factors. There's a couple elements of something being valid. And so, one, if you're pediatric ready, can you provide great care to kids is sort of one piece of it, of a valid term. And then the other piece of it, of course, is like, does the public know what that means? Does when they drive by it on the highway, what would someone assume pediatric ready? Like, what's their expectation? And so we're doing a lot of work with respect to understanding what the family would expect for if a hospital called themselves pediatric ready. So step one was our commitment to this collaborative, and we appreciate everyone's insight and learning from each other's both successes and struggles. We're in the same boat as you all. Unfortunately, we do think that we're going to be doing this independent of the rest of the New England states, because of different regulatory red tape and such that different states are facing, which is sort of unfortunate, because there's obviously a lot of commuting and cross-pollination of patients and their families in this region, but it is what it is. So our next steps go like this. We're going to be excited to learn what the final recommendations of this collaborative are, and we will absolutely incorporate them into our revamped tiered format. We'll likely simplify it from 3 to 2 tiers. And as I alluded to before, we're going to aim for a family-centered high bar process. We're really thinking of, if we're going to call a place pediatric ready, we want that to feel a lot like a stroke center being stroke ready, or a heart center being heart ready, and less of it being kind of just like a label we put up there as if it's a participation trophy. And ultimately, we look at this whole work as with the family as the ultimate consumer of this designation process, and for them to fully understand what they're getting if they drive into a hospital that puts this designation on their website, et cetera. And so the way we're tackling that end is we first did some focus groups with with a diverse set of families. We learned some really interesting ideas as to what they would think the term pediatric ready would mean. And we generated a whole bunch of items from this focus group. We then distributed a survey throughout our state, ideally capturing family members from all quadrants of our state and all backgrounds. And we included the items that the focus group generated, plus the items that pediatric readiness from our expert conversations over the years have generated to be important. And we're looking to describe, again, what the family members think pediatric readiness means. And just as like a really trivial example, when we were doing focus groups and some of the concepts, some of the comments that came through from our survey, just this idea of calling it PEDS ready was wildly confusing to family members. Some wrote, I would never go to that hospital. It sounds like they only manage feet, or this to me triggers the term pedophilia. And so I don't think anyone on this call would want that to be mistaken for the work that we're doing. And I think that just goes to the point of how important it is that as we advertise this, as we really think through what this process means in our state, that we're really explicit about our terminology and what it means for the ultimate consumer, which we look at again as the families. I'm happy to take any questions.
Thank you so much. Questions do you all have?
So Michael, is the term that families had settled on is just to use the full pediatric ready?
I mean, that's just been our small, I haven't done the analysis yet of our, again, we have over 150 responses and we're hoping to get like 200. But both from focus groups and just from reading through a few of the comments that were part of our survey, it was like, please don't call it PEDS, because everyone says PEDS ready, not PEDS ready. And again, just like a simple thing like that, I think is so important for us to really make sure that we're thoughtful about how this is received.
Fascinating. Thanks.
C-suite buy-in. So for example, at least the medical director of the emergency department is sort of where I've drawn the line. We have such exceptional models of the right way to do this kind of PEC work, and that's Middlesex Hospital in our state, where we have amazing nurse and physician PECs. And then we also frequently will get feedback from their medical director. They've created a PEDS specific quality improvement kind of group up at Middlesex Hospital in Connecticut, where the medical director is completely supportive of and even funds some projects that they do. So that's kind of the buy-in at a minimum that we're looking to have. Yeah, and then to this question about like, will the highest tier be pediatrics ready? That's our idea of like what it is, right? Like I'm not sure what we would call the entry tier just yet, but I would imagine we're going to have some pretty strict rules as far as like what they advertise and sort of, making it very clear that the ultimate goal is for everyone, if you can, right, to be pediatrics ready, and then figuring out what the entry tier means is sort of like a next priority for us.
Michael, I have one other question. I know you mentioned you're going to try to align with the criteria that come out of this collaborative. Do you anticipate that you will also be requiring sites to take the pediatric readiness assessment and tracking scores over time? I remember.
I think so, Megan. Correct me if I'm wrong. I think what we've talked about in prior conversation on this collaborative, right, is that there are elements of the PEDS readiness assessment that seem to be more associated with good outcomes or drive the PEDS readiness score more strongly, right? Like at the PEC, I can think of others, right? But I also think that total score is actually what the analysis really predicts, and I think there's meaning to that total score too.
Awesome. It seems like it could certainly be used as a, if you're tracking it over time and really aligning with these higher levels of criteria, using families as your focus, that as you see those scores move towards the 90 mark or threshold, that might then be a point at which you could say, now this is the requirement, which is really exciting.
That rings true to me, Kate. Yeah, thanks.
And there's a question in the chat. Do you anticipate any hospitals that are not pediatric specialty hospitals will be able to achieve the top high bar?
So it's a great question. The Middlesex Hospital example, there's 3 sites and only one of them actually none of them have inpatient pediatric specialty or services, and they would definitely meet our criteria. I would send my child to that hospital before I would send my child to some other places in this state that do have inpatient pediatrics. So again, I think the reliability and communicability of that, I don't even know if that's a word, I'm sorry, but like the reliability of the PEC and like the real commitment that is shown to doing improvement work locally and to doing those surveys every whatever year, that it's asked of. Those are the kind of things that I feel like are really predictive of a pediatric ready, not a peds ready hospital.
Are there any other questions?
I just want to thank this collaborative too. I think it's so important, the work that we're doing together. And I think it's fascinating that we're all going to end in a little bit of a different kind of way of doing that. And it's lovely that that's supported.
Yeah. Right, we'll move on to our third update, which will be from North Dakota.
Hello, I apologize, everyone. I do not have slides ready. Anyway, we have an ambulance recognition program that we revamped last year in October, and I'm going to put the link to it right here in the chat. Oh, sorry, I got my tater tot hot dish in there too. So if you guys need something to make for dinner, there you go. We actually, North Dakota had an EMS recognition program years before I started, and they had about 28 of roughly 215 services participating. That's counting all of our QRUs. Since I've revamped it, we only have 2. So I have not been very successful. What I did was there were 3 kind of prongs to the program, and I added more to it. So we look at 6 categories. We look to see if they have the equipment from that 2020 joint policy statement. We look to see, are they doing community outreach? Are they doing CPR classes? Are we doing safety awareness kind of things? Safe transport. The state does have in its administrative code that it requires ambulances to have 1 pediatric safe transport device. And that's the end of it. That's all the description it gives. So in our recognition program, that's what I had to kind of put, that they do have a safe transport device. And then I gently reminded them to not transport on somebody's lap. Then we also have a education requirement, which I felt could have been stronger. It's 4 credits of pediatric education for every member of the service every 2 years. And if folks are paying to like the HEC symposiums, the Midwest EMSC symposiums, the ECHOs out of New Mexico, and all the other wonderful education that each of our states is providing, 4 credits is nothing. So I thought that was pretty easy to get. We also included a little bit about disaster preparedness. And what was interesting about that is, as I was trying to get something together there, if you ask the question, how are you guys prepared for a disaster? What does that look like when it comes to children? The answer is, we call the state. So knowing that, going into it, I chose to focus on, okay, what are you going to do if there's a school shooting in your town? And just had a question sheet, kind of just to try and get people gently thinking about, what are we going to do if there is a disaster like that? And I have to say, I'm kind of shocked that I even got to keep that in my program, because it kind of brushes gently up against some gun control. Then we also require a PEC to be considered for this recognition. But here, all they have to do is attest to these things. I wanted to put an inspection component in, but that got vetoed by powers higher than me. So I felt like I kind of lost a lot of ground if I can't go around and inspect these people before I award them with Pediatric Ready. So basically I took a 23-page program. It got knocked down to 11. We do give an extra year if people do things like make sure their service members are not on the sex offender registry and they don't have a violent criminal background. North Dakota does not require fingerprinting at this point, so it was just an extra little piece that we thought might benefit everyone. There's been a lot of struggles because while this program is, I thought, fairly straightforward and almost too easy, I'm wrong. Because it's been out for almost a year and I only have 2 ambulance services that I've recognized. So I'm learning a lot just in that. I thought I had really nice buy-in, and I had a lot of people working with me to develop this. I have a lot of EMS on my advisory committee. I had been in meetings with the North Dakota EMS Association. I've worked in 3 different emergency rooms across the state, so I know some EMS folks and was bouncing things off of them. But this is still too much paperwork is the feedback I'm getting from folks, that it's just too much paperwork to do. I talk about it at conferences. I have delightful little decals that are ambulances with the teddy bear driving to kind of entice folks. We also let them borrow our gigantic electronic Andy the ambulance. I think a lot of you also have Andy to use for their community events, but not a draw. So then I got some feedback from the HRSA side of things, and I have a lot that I can improve on. So I apologize because this is not a presentation about a successful program. This is a presentation about a program that has some improvement that we'll be looking at doing kind of going forward. So those are my struggles with the ambulance recognition program. Questions, suggestions, other recipes that we want to share? So license, oh, that's a good question, Sam. They used to be, but COVID has kind of thrown off inspecting ambulance services in North Dakota. We're trying to make an effort to get back into that, but we don't have enough people and a lot of the things that I'm sure other states are facing. So they do have a specific equipment list. I made a very nice list for them with their required by state equipment and also the joint policy statement equipment, and that was taken out of the application, and I was by people with more power than me, and this is kind of what I was left with. Sorry. Ooh, Jordana, virtual visits. I had not thought about that. I am going to write that down, so thank you.
Thank you so much for jumping in and sharing today. And we're not looking for successful programs or the most put together program. The opportunity here is for everyone to hear your experiences and learn from one another and pick up little tidbits, like maybe thinking about a virtual visit and implementing that in your own recognition program. So I think this speaks to exactly what we're hoping to see it get accomplished by hearing updates from one another. So thank you. I'll make sure there weren't any other questions in the chat that we might have missed for you. Right. And after maybe hearing a little bit about what's going on in North Dakota, are there any else who's had similar experiences and steps you've taken to overcome some of that we can offer today? Anyone's had success overcoming that like initial onboarding hurdle, seeming really daunting to do the paperwork? Any steps that you've seen successful to help overcome that? Other thoughts on that? Experiences to share?
Have you thought about making the inspections something where they would, just like STEMI and stroke, qualify with distinction?
I had not, but thank you, because that's being written down now too.
Yeah, because that's a practice with, STEMI and stroke and systems that they, from the American Heart Association.
That, and then I think I saw, was it Andrew? You were also off mute.
Yes, ma'am. I was just curious, to Miss Johnson's, the wealthier, I guess, counties or areas that you guys are having issues with, are they privately owned services, like, or are they like county owned services? Kind of like is it like a local? For example, like is it like something like AMR where it's like a privatized company that's over that particular areas and they chose to participate, or is it like something like in our area we have something called Vicksburg Fire Department that their fire department EMS is the same thing. It's under their jurisdiction. And the reason why I asked this is because we're slightly different in terms of how we do things over here. Our state EMS office, which I'm part of, actually does like regulatory aim inspections. We do every truck twice a year. That's required out of our rules and regs. So I was just curious about from my perspective. I just wanted to know just kind of a little bit about that, just because it's different from how we do national level.
I don't want to take away from the next presenter, but it is public safety 911 responding EMS agencies that are county based or large city of Baltimore. The commercial AMR inner facilities are by law inspected every year by our staff. We can talk offline. I don't want to take up everybody's.
I didn't want to. I appreciate it. Thank you for answering.
Great. Thank you very much. And then next up, we'll be hearing from Wyoming.
Good afternoon. So I just threw our hospital recognition program, our folder that we send out to all our facilities, in the chat. So if anybody wants to look at that and use any part of it or steal all of it, I'm good. Or if you have some great ideas for how we can improve it, share those as well. Wyoming, it being one of the western states, being mostly frontier rural with just a couple small urban areas, we look at things a little bit different in a lot of circumstances. We don't have necessarily an application process to get in. Currently, we're just doing hospital recognition, but we have direct contact with all our facilities. We have a large total of 29 receiving facilities across our state. And currently we're at just about 35% of those that have been recognized, which percentage rise sounds really great, but still only 10 facilities. So our first facility was recognized in 2019. Currently, we just have a 1-tier process. The program is designed to be 3-tier. And with that, recognizing facilities outside of our state with our top tier, lending mostly towards the children's hospital. So for us would be Primary Children's in Salt Lake and Colorado Children's in Denver. Could end up being part of our program and recognized by our state as a pediatric ready facility as well. So we're working at, we have 2 hospitals that keep knocking on doors like, hey, when's level 2 coming out? When's level 2 coming out? And we were working on that, but then as we got into the collaborative, we're like, okay, we're going to pause on some of that development to kind of see what, we all think about and what we all kind of look at as, the important topics, important items that need to be in there. We have everything, obviously, equipment lists like most places do, to education requirements, and then the policy. The biggest thing we found with our facilities is they already have a lot of this requirements in practice, but they may not necessarily have them written down. So a lot of times it's just taking their practice and putting it into a policy or a procedure and working that through. So just some of the things we've got going there. We've our EMS side, very similarly, we're looking, one of the things we do in our region, our NESEMSO region with our EMSC or our PEC partners, is we have a regular meeting amongst us as the state coordinators. And we've had some talks about how do we all, as we develop these programs, develop them in a similar nature so that we have a service in Utah that comes into Wyoming on a regular basis, that when they go to have recognition in both states, it's not onerous in being that very different across those state borders. So we're kind of looking at it that somewhat as a regional aspect as well, to see how we can all work together to make things happen and make things work and not recreate the wheel. So the unique part, especially listening to our friends from Connecticut, is we have a very, in my opinion, weak PEC process right now. And most of the facilities that are coming on board are developing their PEC program, developing their PEC job description through the recognition process. So we're looking at how we can help them define that job description a little bit better for their PECs in our facilities and upcoming into our EMS agencies as well, and working on how that all works across both domains as we continue to grow it and make it bigger and better. So we've had our first hospital that we reached out to that said, nope, we're not doing this. It's just one more checkbox we have to go through, one more assessment, and we don't see a need for it. So the interesting part is they're only one of our 2 counties that have 2 hospitals, and their neighboring hospitals like, cool, if they're not going to say no, we're going to step up. We're going to make sure we get done before they even think about it. So some of that just internal competition across facilities. So we've got those things going on. I had one other important point that I just forgot. So, but we're growing it. We do from our EMS side, do biannual inspections of all of our ambulance services. So that's easy, as well as with our office being part of our EMS office, all of the equipment for the pediatric ambulance side is required on our regular ambulance inspections. So that part's already in place. The other cool thing that we are doing, like the ACS did for level 1 and 2 with the pediatric requirement, we're currently working with our trauma program. They're starting their rules rewrite, and our trauma program is wanting and has reached out to us to put pediatric recognition into our trauma rules, so that anytime a trauma assessment is done of a facility, a pediatric assessment will be done as well. Where that's really cool for Wyoming is trauma assessments are not voluntary in Wyoming. It's a requirement that you participate in the state trauma program as a facility. So once those rules are established and approved, and once they get through their first set of recognitions, every facility in Wyoming will have a pediatric recognition. And we do our state we offer both ACS and state approval for our trauma programs. We only have one ACS verified facility within our state, and that's one level 2. Everybody else is a state recognized facility. So that's kind of what we have going on in Wyoming. Stand for questions.
Thank you very much. What questions do you all have for Scott? question in the chat for you. What staff is completing your site visit?
So our whole EMSC staff includes myself. And then we have two contractors. We have a contractor that we give about a quarter FTE to, that is kind of our recognition individual. Then we have our FAM that we actually contract with. And so right now it's myself and our contractor that go out and do the site visits.
Yeah. And then currently, what is your team's approach to data collection? What tools are you maybe using, or tips and tricks?
So what we do is when we do a site visits, we go out with the document that I uploaded there, and it has a checklist in it. And when we do a virtual initial visit with the facility coordinator, as we're calling them, and we say, show us each of your policies, send us a copy. And then when we go do we call it our kind of our dog and pony visit, where we invite them to bring in their C-suite, bring in their, meet local media and such, and folks like that. We give them a selection of 4 or 5 policies that we go through and say, hey, show us you have a policy on pediatric disaster management, or where in your policies it works. And so we do that. The one thing that we are lacking on that we do have to figure out how we're going to handle is revisits and recognitions. And that's one of the things we're talking about right now amongst our kind of our little crew and our advisory committee is, how are we going to do that? Or is this just always a once and done? But we know that doesn't always hold places that, as they have staff change, that different priorities get pushed towards the back.
Well, if anyone wants to share a bit about your state's re-verification process and how that process began, or like went into those considerations. Is anyone else considering how re-verification might look in your state? Right, hearing none. So we had a last minute sign up this morning from the Northern Mariana Islands. We have anyone from that team on? I know it's very early in the morning, but we do have some comments in the chat now about re-verification. I don't know, Evelyn, if you're able to come off mute and maybe expand a bit on that.
Sure. Our state has been doing facility recognition since 1998, so we currently have over 100 hospitals that are participating in the process. It did take several years to develop a renewal and re-verification process, but we are able to do 2 to 3 regions each year out of the 11 regions that our state is divided into. And with that, we hold an educational session for those regions a few months before their renewal applications are due. So we're able to travel to those regions, give them an overview of the pediatric facility recognition process, because as mentioned, there's always turnover, there's always new people, there's always other priorities, and we lost a lot of folks during COVID that ended up moving on, and so lost some of that longevity and some of that institutional knowledge that had already been there regarding the facility recognition program. So the educational sessions are really helpful. We review the renewal application packet. We outline the expectations for what needs to be submitted and also give them some information about the site visit. And then they're provided with the renewal application. They're given a couple of months to submit that. Those undergo review, and then we set up revisit dates for them to be scheduled for their in-person renewal site visit.
Thank you for sharing. Does anyone have questions regarding re-verification that maybe Evelyn could help answer? A couple comments in the chat, trying to just get through the first visits before you start considering re-verification. Right. So the other group that we had signed up for today was from the US Virgin Islands. They're dealing with some power outage and didn't see anyone in the meeting from that team, but if you're here, let me know. Right, so again, thank you all for sharing. Your presentations have provided some great insight into the pediatric recognition programs within your states and territories. Your experiences provided valuable takeaways for all of us, and we appreciate your time and effort. As we begin looking ahead for what's next for the PRRPC, we look forward to hearing from more of our participants over the coming months. And again, thank you to those who have signed up to share an update during a future session. If you have not yet signed up for a time slot for an upcoming session, you will be receiving a reminder this afternoon. And as of this morning, here is the breakdown of which states will be sharing an update when. And for those of you who have signed up or will sign up for a September update, I will be reaching out with more information tomorrow. So we have quite a few slots available for September and a couple for October and November still. So we will be sharing with those again who have not yet signed up so that you have an opportunity to share with us. Are there any questions related to the process of providing an update and sort of what we've gone through today?
Just want to reiterate what Michael Goldman said on the call when he was giving his presentation. Just there's always going to be some variability between our programs, and I think that's how we learn so much from each other. And it's just so exciting to hear about the work that's being undertaken and underway. And at the same time, while there is, you know, the differences, the nuances, the approaches that are slightly varied, we are working towards the singular goal, and exciting to see what comes next over these coming months. So thanks to those of you who presented today and shared your challenges as well as successes. And we look forward to hearing from others. So thank you.
Thank you. Right. And then we have additional resources coming our way. As we shared last month, we're continuing to finalize resources related to the consensus-driven criteria. And then if we recall back in March, we had Emily and Amy who spoke on how to communicate effectively about pediatric readiness recognition. And they had collected your feedback on which materials would be helpful. And to begin work on those items, they set out to develop some key messages, and they would like your input on these proposed items. They're to be used as guides. This is an internal tool to be used as a guide to develop those future resources. So we will be sharing that with those state partnership program managers so they may provide some feedback. And then we did want to leave time today to hear from you all, see if there was any questions or items that we could help address. So the floor is yours, and we would love to hear from you.
Casey, just a quick clarification. Are those key messages going to be sent out to us, or have they already been sent out and I need to go find an email?
I will be sending them to state partnership program managers.
Perfect. Thank you.
Again, this time is yours. However, we can best assist you. Any questions that need to be addressed, we would love to do that now.
Miss Casey?
Yes, Andrew.
Yes, so it's not really a question, but it's a kind of a thank you from my state. I've heard that you guys are doing like a recommendation letter for a lot of us on the state side, state programs. And I want to thank y'all because my director actually sent it up to our, it's kind of like gave them a pre-warning of, hey, you're gonna get a letter from the EIC, EMSC people, EMSC people for doing so well on the survey. And he actually wants me to sit in on the our next Board of Health meeting and actually explain our program, kind of like sit on our Board of Health and kind of explain what our program is on a state level as well as a national level, and try to kind of push a pro pediatric agenda that we're trying to work on here in the state. And if there's anything that you guys would recommend me in terms of just kind of like general information that you guys would like to recommend for me personally, recommend to our Board of Health that you would like to kind of just in the city's Board of Health, that you guys would like to kind of see in the future. I mean, we're still on the back end of our stuff, but since I have this opportunity and it's a very big opportunity, I would like to know if there's anything you guys would like to see from just me in general, from our state, like or in general from states. Like a question I would like to with us ask our Board of Health to kind of for them to factor in to kind of help us in general in the future. If that makes I know I'm not wording the question very well. It's kind of hard to.
Yeah, I think two parts. I see Mike is still here. So Mike, if you want to maybe share a bit about that letter that I think Andrew's referring to.
Sorry, could you just repeat that, Andrew? The question about the letter, what letter?
No, he has the letter and it's led to an opportunity.
So I'm assuming you guys know about there's a letter of recommendation, you guys. It's not, I guess not recommendation, but kind of like a good job, like a good job letter for doing so well as a national, as for doing so well in the
on the PPRP.
Yes, sir.
Yeah.
And I told my director about it. My director told our state officer, who has been wanting to do a pro EMS agenda because we're kind of behind on their EMS stuff as of lately. And he actually wants me to sit in on the next Board of Health to explain the EMSC program itself. And I didn't know if there's anything that you would like me to, besides like our general goal and everything that we're trying to do, is there anything specific or anything that we would like, that you would like me to present to our Mississippi Board of Health, if that makes sense?
I mean, it sounds like a good opportunity for you to promote your activities at the Board of Health. You know, and I don't know if you've already had a call with Andrea. She's, I know, coordinating the letters that she wants to, you
Yeah,
know.
that's what I'm saying, like, I was talking, well, the talk with Andrea, and then I explained that to my director, and she said, and we haven't gotten to it yet, because I know everybody's still submitting all their names and everything, it's just kind of like I've told my director, and she kind of told her state officer, our state officer, to kind of give them a full warning of, hey, you're gonna get a letter, you know, I know you get a bunch of emails, but, you know, look out for this letter, it's good, it's good for EMS in general, as well as pediatrics in general. And he said, well, that's good, because it's something that I want to show that our national is doing better, as well as our state's doing better to our board of health in Mississippi. And I didn't know if there was anything that you would like, that you guys, like as the EIC would, at EMSC, would like for me to bring to them, besides just kind of like a general consensus of like, hey, we need this, this, and this, but if there's anything specific that you would like me to bring towards them to push, not necessarily push, but kind of like, hey, this is something that really is working well, besides, you know, the obviously I'm gonna mention the PECs, the searches for pediatric equipment, the kilogram, like weighing kilograms and stuff like that, and then the as well as the emergency preparedness for during disasters. I'm going to mention that, but I mean, is there anything specific that you guys would like me to mention, or any information that you would like to provide for that? I'm sorry.
So I'll just say, Andrew, we're actually working on a document that helps to crosswalk the minimum criteria that are listed in the EMSC performance measures manual with the consensus criteria that folks have agreed on here, and the overarching joint policy statement recommendations to try to help and assist, I think, with the questions that you're asking. At a minimum, you know, if you look to the performance measures manual, you will see bulleted the items that you just identified as, you know, absolute minimum to, you know, really try to move forward with this performance measure. But we understand that there is some confusion around these criteria and the discussions that have happened. So we didn't dive into that today because we don't have a final document or communication specifically to share with you with you yet. But we are working on that to help support you. And hopefully that will overcome your confusion around those pieces. Does that help? And if there's a specific timeline that you're working with that's urgent, please reach out to us offline and we can help to work with you directly.
No, ma'am, I appreciate that. Thank you. Sorry for taking everybody's time. I just thought I would ask, since, you know, we were all here.
No, this is open discussion and questions, so you are 100% on point to ask questions that you know you need to ask. And yes, you know, as Emily put in the chat, work with the HRSA project officers to have supporting documents reviewed by the federal program before starting. And I think this is just to make sure that you know, they're trying to provide feedback and support to you, and we're here to assist and help you overcome any barriers as a group, all of us, not we EIC, but everyone as part of this collaborative. So it's just trying to move towards, you know, hopefully eventually more standardized criteria.
Thank you. I think Kate was able to answer a bit of Andrew's question and some of what's going on with the chat. I'm just looking at all that's going on in the chat now.
Can someone help clarify what that actually means? Because I think that's a really nice thread that's being talked about, like review, not approve. Can someone explain like what is the review process when you want to bring it to your project officer? Like, is there a process? Is there a protocol?
Sam, I can try to provide a little bit of background. So I think what HRSA project officers are trying to keep track of is what programs are currently in place, the stage of those, and what's being developed. And the ask more or less is as you begin developing the program and have kind of a final plan set forth, that those documents, the overview, the description of the program be sent to your HRSA project officer so that they can keep track of what, is actually happening, what's being put out. And they, may provide some feedback that suggests that it may not entirely align with what is in the performance manual or not, just depending on what those criteria are. Within the performance manual, though, there are a minimum criteria that are suggested to meet the measure. And so I think it's to provide feedback to program managers on, whether it may or may not meet what is intended within the performance measure manual, but also just to provide some additional resources and or guidance if needed. Hopefully that answers your question, Sam, but please let me know if not.
What other questions do you all have? Well, if there are no further.
Yes.
Oh,
If I could just address Emily's comment, because I do think there's a lot of confusion. And as I was saying to Andrew, we're working on some guidance around this, but you're right, Emily, if you look in the performance measures manual, it lists some recommended criteria and it lists a minimum set of criteria. And those are what HRSA is using to say whether a program meets the standardized recognition program specification.
Yes.
And it also highlights on that same page that there are a number of other criteria that programs should be aiming towards or that are recommended or should be part of that. And what we were trying to do here in this collaborative is to figure out maybe above and beyond what are the absolute minimum where we can work towards next. And that's what so much of our discussion has been around. So to Kelly's point, work with your HRSA project officers. I certainly do not want to speak for them, but they will let you know if when you share your program documents, whether they meet the criteria as intended. So hopefully that's helpful. Again, if you have specific questions, you're welcome to reach out to your HRSA project officer offline. Or you're also welcome to reach out to us directly, or we'll help to try to guide any of your questions. See, it doesn't look like there's any other questions in the chat, so hopefully we've answered them as best we can. And if you do have any follow-up questions, please reach out.
and we can stick around for a couple minutes, but if you have no further questions, we can give you a couple minutes back in your day, and we look forward to seeing you again next month.